My name's Jim Giles and I'm going to try and explain why healthcare in America needs to be reformed. There's clearly a problem with healthcare in this country. There are large numbers of uninsured people, and those people that do have coverage are paying more and more for their insurance. Now, there's a healthcare reform bill making its way through Congress, but I want to leave some of the political arguments aside and take a scientific approach. I want to take a look at the data that can explain why there's a problem with healthcare in America. We need to start with an international comparison. Take a look at this graph. It shows healthcare spending for 7 rich nations per person over time, and it begins in 1960. And you can see that as the graph starts off, most of the countries are bunched together. They're spending roughly the same amount per person. But beginning in the early 80s, America, which is in red, starts to move away. And it continues to move away until the data runs right up until 2006. And at the end, you can see that America is spending roughly $7,000 per person on healthcare. The next highest spender is Canada, which is in blue here, and that's spending just about half as much as America. Now, you might think that Americans are getting a better quality of healthcare for all this extra money, but that's not the case. Let's take a look at one more graph. This graph here shows healthcare spending per person on the vertical axis against life expectancy on the horizontal axis. Now, a country with a good, efficient healthcare system would expect to see their line move across to the right, indicating better life expectancy, without moving too far up the graph, because that would mean they were spending a lot of money. If we let the graph begin now, you can see that as before, at the beginning, the countries are pretty much all bunched together. They're all moving to the right and getting better life expectancy. But again, in the early 80s, America starts to move apart. Its line is moving up the graph. It's spending more and more money, but it's not moving so far to the right. It's not getting the healthcare benefits that other countries are. And when the data finishes, we end with America here with a life expectancy of 78 years, which we can compare with Japan, which is in yellow, which has a life expectancy of 82 years. That's a dramatic difference. Now, to understand why America is different, we need to look within the country. Different parts of America do not treat healthcare in the same way. I'm going to show you a graph here for healthcare spending on senior citizens per person for 3 parts of the country. Miami, which is in blue, San Francisco in yellow, and Salem in Oregon in green. If we start the graph going, you can see that even at the beginning, Miami is spending a lot more than San Francisco and Salem. But as the graph runs, San Francisco and Salem seem to be keeping their costs roughly constant, whereas in Miami they're increasing. And by the time the graph ends, we have Miami spending 3 times as much per person on healthcare as Salem, Oregon. So you might think that patients in Miami get a better quality of healthcare for all this extra spending. But just like the international comparison we looked at, that's not the case. I want to try and illustrate that by looking at one particular clinical situation, the survival of elderly people in the year following a severe heart attack. Now, the data we have up here is the death rate for the lowest spending regions of the country. They're marked on the map there. And you can see that just over 30% of elderly patients die. Now I'm going to add the data for the next 3 higher spending regions. You can see there isn't much difference. In fact, if I add data for the highest spending regions of the country, which include Miami, you can see that they have the worst death rate. Miami is spending all this extra money and it's actually achieving the worst health outcomes, at least on this illustrator. So what's going on in places like Miami? Well, we can try and get to the root of it by considering an imaginary clinical situation. Imagine an elderly patient shows up at a hospital complaining of chest pains. At this point, doctors have many different options. They could just ask the patient to come back for regular checkups. There's also a bunch of tests they could run. And the problem is, many of these tests are expensive, but they haven't actually been shown to improve patient outcomes. I just want to consider one of those tests, which is the heart ultrasound or echocardiogram. Now, the data we have up here is for the lowest spending regions of the country, and it shows us that 15% of physicians in these regions would recommend an echocardiogram for the patient I just described. For the moderate spending regions of the country, it's over 25%, and for the highest spending regions of the country, it's up to 40%. Now, that's just one example, but researchers at Dartmouth University, who compiled the American data we've just been looking at, found many others like it. Many other cases where physicians in high spending regions of the country were using expensive tests and treatments which haven't been proven to help patients. Now, there are many different reasons why this might be happening. We know that in places like Miami there are simply more treatments available, which makes it more likely that physicians will use them. But it's also true that some physicians own devices like echocardiogram machines, and that introduces a strange incentive. It's in their interest to prescribe those tests because they get paid every time they're used, even though it doesn't necessarily help patients. And this is one of the really important messages to come out of the Dartmouth research. The incentives in healthcare in America are all wrong. We have a system that rewards physicians for the quantity of care that they provide. We need one that focuses on quality. Now, this is one of the issues that politicians are going to have to grapple with as the healthcare reform bill moves through Congress. And one of the things they could do would be to make more use of what's known as comparative effectiveness research. These are studies that look at treatments and tests, things like echocardiogram devices, and find out exactly how useful they are in terms of patient outcomes. If we had more of that data, we could make sure that physicians use the tests that really help patients, not just the ones that make them money. Now, if you want to explore the data we've been looking at in more detail, there's a video tutorial below which shows you how to play around with the OECD international data that we were looking at the beginning of this presentation. And all the Dartmouth data is available on the researchers' website. There's a link to it below. Thanks for listening.